Welcome to our podcast, PA Mindset Matters. I'm Jessica Spissinger, and we're excited to introduce you to our mini mindset editions.
I am Mercedes Dodge, and we created these short episodes for PAs, PA students, and all healthcare providers who want a moment to pause, reset, and reconnect with purpose.
Each episode, we will explore a reflection, practical insight, or mindset shift you can apply right away in training, in practice, and in life.
Because how we think shapes how we show up for our patients, our colleagues, and ourselves. So let's get started.
All right, it's good to see you. I'm so excited to do a second part of my seasonal affective disorder series. Today, we're going to talk about spring-onset mania. Have you ever heard of that?
No, I don't think it's a very common thing, honestly. The more that I treat and look at bipolar research, I realize it can be a trigger.
Not to say the seasons are always the reason, but they certainly can be a big trigger. I had this slide last time for my first seasonal affective disorder on the winter onset depression. And this is a good point to make is that with seasonal affective disorder, it's not its own diagnosis, but it's really the seasonal onset component of a certain diagnosis. So with major depressive disorder, we see it generally in two phenomenon. We see oftentimes the winter onset, but there's also a summer onset. But what's less spoken about is a seasonal onset with bipolar disorder. Yet when we start to get into the evidence in literature, you'll see there's actually a whole lot of data that supports that going on a lot more than I think is being highlighted. So for any kind of seasonal onset diagnosis to be made, you have to have that regular temporal relationship with the onset and remission in a particular season for at least 2 years. So really looking for patterns. So if somebody has like a spring onset kind of around that time manic episode, but they're also having one in the summer, one in the fall, one in the winter, and or more often, then we're not necessarily going to attribute that to a seasonal pattern. We're really looking for more of this like specific cyclic events. So differentiating seasonal onset mania, we're really talking about just all of the features of mania, which you may remember DIGFAST. Do you remember that as the mnemonic? DIGFAST. And just like with SIGI caps for depression, it doesn't always encompass all the elements of mania, but it does help to really highlight some of the different components.
D is for distractibility, I is for impulsivity, G is for grandiosity, F is for flight of ideas, A is for activity increase, S is for
Mhm.
sleep depth, and T is for talkativeness.
Love that. Thank you. You win a gold star. You would have 100% on that test. So just to say like that all of those symptoms and components are really what comprises a manic episode, but that's not the same thing as a psychotic outbreak. However, in addition to the DIGFAST symptoms, psychosis can be present. Sometimes there's a little bit of that fine line with grandiosity, which can go into like delusion. But when somebody has actual like psychotic symptoms present, like hallucinations, delusions, we're talking more about that manic episode differentiated from a hypomanic episode. So again, what's interesting is that there's about 15% correlation of manic episodes having these seasonal patterns. There's these peak incidences. Today we're talking about the spring onset, but there is a second peak in autumn. So maybe I'll have to do a fourth part on that. And here, we're going to talk about the pathophysiology more than last time, but just like with winter, it does seem connected to those light exposures, again, affecting the suprachiasmatic nucleus, melatonergic systems, and photoperiodism pathways. And those are really the elements which help us to sleep regularly. And as we know, people are most at risk of having manic episodes when they start to have those periods of not sleeping, but not feeling tired from it. So temperature also can increase the odds. And then, of course, something to keep in mind is we're always trying to differentiate between a hypomanic versus manic episode. In your mind, what is like the key differentiation between hypomanic versus manic? I kind
I
of
think
already
the
said one
first,
part, but
yeah, right. I think that first, there's several parts, but the first thing that comes to mind when someone asks me like that so quickly is
mhm,
4 days and 1 week. So
mhm.
I think of duration of time, and then obviously the severity is going to be the next thing I think about.
Same. Bipolar 2, you have to have had a diagnosis of a major depressive disorder. And the hypomanic episodes are most often are not so severe that they cause as dramatic of a functional impairment versus a manic episode where fast track to the hospital. Some of the triggers that happen in spring are these abrupt daylight changes. Here in Massachusetts, we've just gone through that this past week, where last week we set our flux forward and suddenly it's light until 7 instead of like 5:30. Like it just really jumps quickly. Starting to see some green stuff. The snow is melting. Temperatures are getting a bit warm. And it's normal for people to have a spring in their step. That's why we call it that. But with a manic vulnerability, that spring just becomes like trampoline taking off.
And I think one of the things that made me realize that it was happening was that it just gets a little bit harder to get up and start your day.
But then a little bit partly sluggish because you're a little bit more activated in the evening with a little extra light exposure. So, risk factors to having a manic onset, spring induced manic onset, is really just the same of any kind of manic risk factors. Really, it's that history of mood disorders in the family. Female tend to have higher risk more than men and more likely onset in those younger years. And some people may just have this like predominant polarity, which is just activated, by vulnerabilities more than others. And there are some genetic factors. It is always just interesting to question, like, how does seasonal change wind up inducing a whole like pathophysiology reaction for us? And again, it just boils down to that circadian misalignment. There are some neuroendocrine dysregulation factors. There's our own environmental triggers and our own biochemical genetic susceptibility. And like I said, these abrupt shifts with when we artificially just change the clock. I like this slide here. It really highlights that hospital admissions for mania peak exactly at the spring and the autumn equinoxes, which is fascinating. And this really is kind of pulling together like some of the different facets that could be precipitating factors. I found an article that suggests that metabolic dysfunction is another element, like insulin resistance and type 2 diabetes can be risk factors. And then again, we keep kind of hammering it in, but those circadian disruptions with that hypersomnia kicking in and not remitting, and people developing like delayed sleep phase reactions. Interesting to note that lithium, which is gold standard for bipolar treatment, especially, actually can alter both glucose metabolism and the circadian clock genes. So, really cool stuff out there. Here's another fun slide that I got from kind of compiling some information from several different articles, which are referenced towards the end. And it's really looking to say over time, like how much has our evolution been linked with circadian rhythms, which have developed some vulnerabilities for some people versus others. And certainly we have evolved to be able to anticipate time changes with these different photo periods and food availability, right? In like the northern climes back in the day, like it would be down to like roots and like maybe some dried meat if you could find it versus the more like bountiful nutrition available during the warmer climates. And so people really had to adapt to that, and sometimes sleeping more soundly in the winter and that kind of quasi hibernation period was the way to coping. So really looking back even like into the Neanderthal genomic sequences, you'll see some elements that are related to the circadian clock variations. So this is my history slide for today. Also, these different terms, torpor, which means hibernation, which kind of makes sense, like you're in a torpor, eh, which is a spring arousal driven by hyperarousal for migration, mating, and foraging. Anyway, cool stuff. All right, so getting back to the circadian rhythm elements and chronometabolic connections, we're talking about these specific genes, and this is where there can be some more genetic vulnerability with the variations and deviations of your clock genes and your BML1 genes. Metabolic dysregulation also has different pathways with insulin signaling and other pathways. And then, of course, we talked about environmental triggers, also some correlation with like light exposure and high refined carbohydrate intake, which kind of circles back to that insulin pathway. Some of the neurobiological evidence as well shows that dopamine can vary throughout the seasons. There can be reduced dopamine transporter availability in the winter. And then in the spring and summer, there's vulnerability of a little bit more of these like dopaminergic swings. If we have very low striatal dopamine activity, there could be some associations with suicidal activity. And so some of those varying points can really help to explain that variation between some of the highs and lows that people going through cyclic manic episodes can experience. The photoperiodic and circadian mechanisms in food and mood disorders, again, we're just hammering back to the seasonal light regulation for mood biology, that with the melaninergic pathways, there's a lot more melatonin secretion in the winter. However, with the abrupt bright light exposure in the spring, that actually decreases. So there is something called like this bifurcation in mania where our suprachiasmatic nucleus oscillators become desynchronized. All right. So pathophys, so fascinating. We don't always keep that in our minds for like real world applications, but it seems to me like there's a really cool research coming out on the horizon. But we are going to dive into some treatment approaches. And one thing I didn't go over is in depth last time with the winter variant is there are some specific seasonal pattern assessment tools This is one, the seasonal pattern assessment questionnaire. There are a few others. When I did an evaluation, this one shows up as like really the most valid, most recommended to use. And so just wanted to make sure there's a link for that. So when you think about your treatment, you really want to first, of course, establish the diagnosis, and this tool could be helpful. Kind of thought to start with acuity spectrum. Oftentimes, some of my students, when I'm teaching them about bipolar, they're like, what's the first line treatment? And it's so confusing that it really depends on what phase of the bipolar spectrum you're meeting somebody at. And if they are in an acute full blown manic episode, your treatment is very different than if they're coming in outpatient saying, I have a history of a manic episode. But right now I'm okay.
No, I think you got it right. I think that's where a lot of people get tripped up. And then because it's not so quick and linear, it can deter people to treat bipolar. And I think that the goal here is to simplify it and understand it. And once we understand like the pathophysiology and the phases that the patient is in, we can break down the treatment plan a little bit easier.
Absolutely. And if somebody comes to you and they're in a pretty florid manic state, you just got to stabilize. And that may mean hospitalization. This is probably less likely used on the average, but just to say that ECT actually can be an option. Most likely, what you're going to do is that combination therapy of both a mood stabilizer and an antipsychotic. And that's because whether your mood stabilizer is like Depakote or lithium, or maybe like sometimes lamotrigine, but inpatient, that usually takes too long to get going. Even though they're heavy hitters, lithium and Depakote take several days to really have their full effect as you titrate up the dose. But an antipsychotic can help to stabilize some of the immediate agitation. It can still take several days for sleep to catch up, even more than a week. So, just like we talked about with the pathophysiology, the treatment is going to match that. And so, really, you can apply this to almost all of these seasonal affective disorders. That the key approaches for treatment are you want to hone in on the circadian stabilization, look at that light and environmental management, psychopharm options, psychotherapy options, and then we're going to evaluate where they're at with nutrition and movement. With spring manic presentation, circadian stabilization is going to be looking like a very highly disciplined sleep schedule because any kind of sleep disruption is really like triggering a huge risk to onset a manic episode. So, avoiding late night light exposure, maintaining dark therapy. So, there's extended times and supported with a very dark environment, whether that's dark light blocking curtains, maintaining consistent daily routines and really just like leaning into sleep. There is some evidence that shows that by like aggressive sleep management, mania can actually be prevented from going into full blown cycles. And again, this is along the same lines, like just that light and environmental management. You really want to look at what the person's day in and day out is looking like and seeing to what degree they can make some changes to reduce the evening light and to work on their sleep discipline. It seems that blue light blocking glasses can be helpful to stabilize their circadian rhythms. So you want to provide education around how that can be useful. With the psychotropics, we do have some gold in our little treasure chest here. Lithium being the gold standard for acute mania and relapse prevention. When it's tolerated, lithium can be such a great medication. It's unfortunate in some ways because it's such an older agent, one of the first psychotropics. It has some like association with stigma, and some people get really disturbed when you recommend treatment with it. But low levels and sometimes like higher levels based on what is needed can be so protective for the patient because every time they go through a full manic episode, that can really cause some cognitive harm. And we want to try to minimize that harm. Depakote, always a good option, but keep in mind, avoid during for reproductive age women. Carbamazepine was kind of like an old bogey. It was used for many years, but with all of the medication interactions, we lean away from that now. And lamotrigine is helpful, but does not stabilize the acute episodes. Any kind of atypical antipsychotics are really going to be effective for rapid control. And that's what we're looking at. And a lot of the third line antipsychotics now, like Vraylar, for instance, like they all have the bipolar depression indication. So there's some new options that are very helpful long term. But sometimes some of these like second gen stabilizers just do really quick, like rapid control. Like I always say when people go inpatient, they must always come out with a Olanzapine. And you don't want them on it long term, but it's like wearing a splint. It's like you got to get the splint to get stable. And then we got to take the splint off, move on to something else. Evaluating what their nutrition and movement looks like is always important. They want to be like doing some sort of consistent movement practices, mindful nutrition, I think we've said enough about the light exposure and sleeping habits. So just continuing to reiterate and provide education to your patients around those components. However, that said, it is very important that you recognize, and of course, we all recognize this to some degree, that some things are just like easier said than done. For some people, they may have strong occupational impacts where maybe they're working like off shift and they're always working like a 3 p.m. to 11 shift. And so then they wind up like staying up all night and then they have a hard time like settling down. People may, you may want to make some suggestions around the sleeping discipline and really trying to lean into environmental control. Some people may just have like limited ability to do that. So all of the recommendations, we just always want to make sure that we're addressing where the person is at. All right, we talked about CBT last time, and it's not going to go over that as much in depth this time because it's really the same idea with seasonal affective disorder, CBT. You're working on cognitive structuring to look at your maladaptive thoughts that are specific to the seasons and working on behavioral activation, whether it's winter, spring, or summer, behavioral patterns, and really trying to engage the patient to maintain their engagement and all of the activities that support them in whatever season they're in. This slide may also look familiar. So this is my kind of calendar approach for someone who is at risk of having a spring manic episode, somebody who's had them in the past. And I really start to take this approach with all my patients who don't even necessarily have a history of a seasonal pattern because the spring is just a vulnerable time. And so as we look at it from a calendar standpoint, by the time we start to come out of winter into January and February, that's a good time to look at how the last several years have been. Maybe you want to do that assessment with a screening tool and think about what was supportive, what were risks in the past, what were vulnerabilities we can help to support them with. Then when it comes to March, we really want to make sure that before that time change happens, that we're in a good place with a mood stabilizer. So between January to March, maybe we're titrating up some doses, we're doing labs, we're checking in on where they're at, and we're trying to do some preventative measures, talking about sleep changes that they can make to really support themselves. Sometimes I will do like a PRN, atypical antipsychotic, such as olanzapine, so that if they start to feel like some of them will say that they start to get the zoomies. And if they start to get the zoomies and they can't sleep, like start taking the olanzapine 2.5 to 5, depending on the patient, and make sure you're protecting those sleep cycles. And I've had some pretty good success with that clinically. As we go into April and May, that really continues to be the very vulnerable period. Once we get to June, we have the summer solstice and we start to cycle back into shorter days. But really from March, May, June, those are the highest risk periods. So you want to be thinking about what does their room look like? What is their light component? Factor in the situation and adjust when possible. Come September, hopefully you've made it through and didn't have a spring onset manic episode. And you just start to lean into the fall. Of course, now we know there's also a fall peak onset. So I'll look more into that. But a lot of people do really well once it comes into the fall. And then they may be at risk for winter depression. And then we start the cycle from a different pathway. All right. So that concludes the second series on seasonal affective disorders. I love talking about this topic. I hope it was helpful. I know we're just scratching the surface, but it's always so interesting. Here's some references. And yeah, that brings us to the end.
Yeah, well, this is great, Jessica. I'm very happy that you dived into this because I think it's not well known. We will have a lot of our slides available on our website, pamindset.com, if you become a basic member, which is a free membership. I think it'd be great for people to dive into those references, and you can also check out our blog. We do summarizations of all of our episodes. But that's the wrap for today. Thank you so much.
Thanks, everyone.
All right, folks, thanks for joining us today for this mini mindset episode. We hope you can take one insight from today and carry it forward into your clinical work, your learning, your life. Small mindset shifts can certainly lead to meaningful change. So until next time, take care of your patients and take care of yourself.